Greetings from Bumrungrad Hospital Talks. I'm your host, Dr. Laura, Doctor of Pharmacy, and in today's episode, we're going to talk about heartburn and chronic acid reflux, or GERD. Heartburn probably is one of the most common digestive problems which almost every person experiences at least once in their life. But why and when it might become chronic? Why it is important to treat chronic acid reflux? What is Transoral Incisionless Fundoplication, or TIF? To answer all those questions, I invited a very special guest, Clinical Associate Professor Dr. Tossapol Kerdsirichairat, a gastroenterologist of Bumrungrad's Digestive Disease Center. Thank you, Dr. Tossapol, for joining us today.
Hello, Dr. Laura and everyone.
Right. May I ask you to tell our audience about yourself, your specialties, and your experience?
All right. So my nickname or the short name is Toss. So please feel free to just call me Toss, and I always tell my patient that way. So my subspecialty is related to the advanced endoscopy, which is like how the doctors use a flexible endoscope to fix the digestive tract issues when the general endoscopic maneuvers could not be helpful. And my experience is that I was in the United States since 2008, and then I just returned to Thailand in late 2020.
All right, that's great, doctor. And our first question is, what is heartburn exactly and why it is called acid reflux?
Oh, so you start with a very difficult question because last year, the American College of Gastroenterology, they just published a new guidelines. And actually, they even said that the definition of the gastroesophageal reflux disease is very difficult. But what we understand is that the GERD, or the gastroesophageal reflux disease, is a condition in which the reflux of the gastric content reflux back into the esophagus that causes symptoms or complications. And there was a presence of characteristics mucosal injury when the doctor saw the lesions under the endoscopy, or they can document the acid exposure into the chest or the food pipe. So that's a brief definition of it.
Oh, that's quite complicated, to be honest.
Exactly.
Right. So, what's the difference between heartburn and chronic acid reflux GERD then?
Yeah, sure. So I would say GERD is like a big umbrella. It composed of two typical symptoms. One is the heartburn and two is the regurgitation. And the heartburn is the most common GERD symptom, and it's described as a substernal burning sensation rising from the epigastrium or the upper abdomen towards the neck. On the other hand, regurgitation is the effortless return of the gastric content upwards towards the mouth, often accompanied by the acid or the bitter taste.
Oh, wow.
So it's a little bit different.
Oh, okay, doctor. So let's talk about the common signs and symptoms of GERD.
Yeah, sure. So I would say there are four common symptoms that the patients usually come to the doctors. The first one is that they can describe as a backwash or regurgitation of food or sour liquid into the throat or in the abdomen. Second, they can describe as an upper abdominal or chest pain. The third one is related to the trouble swallowing, or in the fancy term we call dysphagia. And the fourth one is a sensation of a lump in your throat. So those are the four most common signs. But there are other symptoms that could be a little bit atypical or unusual, such as the infection of the ears, the sinus. Sometimes people can have like a little bit hoarseness of the voice, or they can have like a typical attacks of asthma. So those are called the extra-intestinal manifestation of GERD.
Oh, wow, it's interesting. So actually, some of the symptoms quite similar to heart problems as well?
Yeah, sure. So basically, when people have like GERD, as a doctor, we have to make sure that there's nothing serious going on, such as the heart or the lungs problems. Because when people have the chest pain, sometimes it could be the initial presentation of the heart attack or heart problem. So I often send my patients to our cardiologist to exclude those conditions first, especially those who are older than 50 years old or having a lot of risk factors such as high blood pressure, diabetes, abnormal cholesterol issues.
All right. So here's the question. If you have any of those symptoms you described earlier, when the patient should see a doctor?
So I would say whenever they are in doubt, they should see a doctor. But for those who come like a little bit reluctant to see a doctor, I would say like when you have to seriously see a doctor. Those include the ones who have family history of esophageal or the stomach cancer. Those who have clinical GI bleeding, such as they vomit blood or they have like a black tarry stools, or they have weight loss, or the doctors told them that they have anemia or low hemoglobin. Those are the red flags that you should see a doctor right away.
Oh, thank you, doctor. So the next question is quite interesting. What are the risk factors of GERD?
So for the risk factors, I would like to divide into two groups, okay? So the first conditions are related to the factors that increase the risk of having GERD. And the second issue is about the factors that could aggravate the acid reflux. So what could aggravate the acid reflux? Obviously, you have heard it all. Smoking, eating too large meal, or eating late at night, or eating certain foods, such as a fatty food or fried foods, drinking certain beverages, such as alcohol or coffee, or taking certain medications, such as aspirin. But for those who don't have symptoms, how you can increase your chance of having GERD, there are actually 3 to 5 risk factors. The first one, the most common one, is the obesity. The second one is the bulging at the top of the stomach up towards the diaphragm, such as that the stomach is moving up to the chest, so that the natural protective mechanism from the valve between the food pipe and the stomach cannot be closely tightened when you want to digest the food with the acid in the stomach. The third one, actually, with ladies who are pregnant, they often experience GERD because the hormones can relax the valve that protect the acid reflux, and also the increased abdominal pressure from the baby. The next one is for those who have connective tissue disease, and there are only a few conditions that can aggravate the GERD symptoms. The most common one is known as scleroderma, or people who have like the scars all over the place, such as the fingers, the face, and also the food pipe can be can be involved too, and that can cause the reflux. And the last one, for those who have diabetes, if they have a little bit delayed stomach emptying function, then the acid can stay in the stomach for too long time, and then it can come up to the chest.
Oh, wow. Yes, thank you. So here's the biggest question. Why it is important to treat GERD?
Well, I would say there are two answers to that. The first one is the quality of life. Think about if you have the heartburn or regurgitation at all times. So I would say I myself, once I had acid reflux that I woke up at 3 a.m. with a chest pain. That's not fun. So the health-related quality of life is the most important thing. And secondly, if you leave the GERD undiagnosed or untreated for a long time, you can experience complications. There are 3 main complications related to acid reflux or GERD. The first one is the damage or the inflammation of the tissue of the esophagus, because the acid is causing the injury for a long time. And that's called esophagitis, or the full name is reflux esophagitis. If the reflux esophagitis is going on for a long time, then you deal with the healing process. The scar, when it contracts, it can cause esophageal stricture. So that's how you have difficulty swallowing. The last one actually is more common in the Western countries. So when you have the acid reflux for a long time, your food pipe will try to accommodate itself to tolerate the acid better. But that's a wrong accommodation. So the food pipe lining will turn into something that looks like the stomach lining. And that's actually the precancerous lesion. Or you may have heard the condition is called Barrett's esophagus. So long story short, why we have to treat GERD? For the symptom control, for the quality of life, and to prevent complications such as esophagitis, stricture, or precancerous lesions. I think that's a good reason enough to take care of it.
Oh, this is very great reasons, to be honest. So, what are GERD treatment and management options?
So I would say there are three main items that I want to talk about the treatment. The first one is a lifestyle modification. And if we go back a little bit about the lifestyle modification, we have to remember the risk factors, right? So you have to limit the alcohol or coffee beverages. If you have obesity, you have to manage that. And if you have scleroderma or connective tissue disease, you should see a doctor to have the disease in good control. So those are the lifestyle modification. I often tell my patients that it's very important for them not to lay down flat within 4 hours after the last meal or the last snacks. Why? Because if the valve between the stomach and the esophagus is not tightly closed and you lay down flat right away, things can go up to the chest and can cause the symptoms. And they have to get the meals on time, right? Because your body try to adjust the acid and you want to control that schedules to be on time so that you can take the medication to make the best benefit of it. So the second one is the medications. So it's the acid, so you use anti-acid. So if you heard about the anti-acid in the past, I would say like for the liquid, the trade name is like Gaviscon. That's actually the basic solution that you neutralize the acid in the stomach. But the more efficacious way is that you take the medication that can suppress the acid production. There are many names that, or the trade names that you have heard before, such as Prilosec, Nexium, Harriet, Dexilant. Those are great. And I would say like if you are not responding to these medication for 4 to 8 weeks, that's a good reason to see a doctor. And the last one, if the medication is not working well, or the patients cannot tolerate the acid suppression medication, or what we call the proton pump inhibitor, then we have to talk about the intervention such as endoscopy intervention or surgical intervention. Nowadays, we have the standard of care, which is a surgical fundoplication, like the wrap that we create from the stomach to wrap around the lower part of the esophagus to create a little bit stronger valve. The second one is we can do the same way that Dr. Laura mentioned earlier, is that we can do the Transoral Incisionless Fundoplication or TIF. And the other option is that they can use a magnetic ring to wrap around the food pipe that can open and close accordingly. And that technique is available too. So long story short again, lifestyle modification is very important, medications, and lastly, interventions.
All right, so, and what are the main differences between TIF and traditional anti-reflux surgery?
So, well, we have to talk about the standard of care first, the anti-reflux surgery. So, to be able to say that, I have to go back to the anatomy a little bit. So basically, after we swallow the food bolus, the food will come to the food pipe. The food pipe, it ranges around like 35 to 45 centimeters long. And then it's going to end up around the diaphragm area. The diaphragm is the area that is a thin muscle that separates the chest and the abdomen. So that's the junction between the food pipe and the stomach. Stomach is in the abdomen, the food pipe is in the chest. So to do the surgery, we have to understand that there are some patients that the upper part of the stomach is actually sliding up to the chest. When it's sliding up to the chest, the mechanism of closing and opening the valve between the two parts, the esophagus and the stomach, is not tightly closing or opening. So then the acid is coming up. So the surgeons can address that by number one, they have to pull down the stomach in the chest, coming down to the abdomen a little bit, okay? And then they have to close the diaphragmatic opening to make it tighter so that the stomach is not sliding up more. Then they're gonna use the upper part of the stomach to wrap around the lower part of the esophagus. It's as if you wrap something to make it tighter so that the acid cannot come up to the chest again. So this is a definition that we call the traditional anti-reflux surgery. You may have heard about the few names such as a Nielsen fundoplication or toupee fundoplication. Those are the anti-reflux surgical procedures. So what TIF tries to address is that it tries to address the same physiology and anatomy. But they don't want to go from the outside. They don't want to go through the abdominal surgeries. So what we can do is actually the TIF device company is created a hinge-like device that you can actually put the endoscope through the device and put everything through the mouth. When it goes down to the upper part of the stomach, you can just pull the tissue down into the device and you start the suture internally. So when you do the suture internally, you can put the sutures about 20 to 40 sutures, and then you can create a stronger valve the same way that the surgeons can achieve. So basically the wrap that they try to do is about 270 degrees to 330 degrees. And we want the valve length to be about 2.5 to 3 centimeters. So again, long story short, the main difference between the TIF and the surgical anti-reflux surgery is that one, the TIF doesn't have any opening, scar or wound, and therefore the patient recovery is a little bit shorter. But the main difference is that if you have a large amount of the stomach sliding up to the chest, sometimes you need both of the surgery and TIF, or the surgeons can fix the hernia first and then they can do the fundoplication right away. While TIF is good for people who have acid reflux that doesn't have much stomach sliding up to the chest, and the endoscopist can wrap it internally and can create the same type of valve from inside. So those are the two differences, the scar and the size of the hernia that makes it different, like which patient gonna be appropriate for which procedure.
Oh wow, that's probably why it's called incisionless.
Yes, it is incisionless, like no incision at all, no surgical wound, no scar, and you have quite rapid recovery.
Oh, that sounds amazing actually. So the question is, how is TIF performed?
Yeah, sure. So I will say before we talk about how the doctors do the TIF for you, we have to make sure that the team that you go to know that patient selection is a key. It has to be done in a comprehensive multidisciplinary heartburn program that has one, the gastroenterologist who specialized in the gastrointestinal motility. You don't want to wrap a food pipe in someone who doesn't have acid reflux, but the abnormal muscle movement of the esophagus. The second one is you need an advanced endoscopist like me or my colleagues who know like how to use the device efficiently. And third one is that you need to focus on the minimally invasive surgeons that are performing the surgical fundoplication with good experience with high volume numbers. So that's about the patient selection and the center that should do it well. To do the pre-procedural evaluation is another key. You have to measure the acid. You have to know the anatomy, like how large the hiatal hernia is, like how many centimeters the stomach is sliding up into the chest. And there are other steps that we have to talk in the multidisciplinary team. We have to be able to offer more than one option to the patient. Then when we think that the patient is a good surgical or endoscopic candidate, or when we think that TIF is best for them, then we invite them to the endoscopy unit. This is basically they work as if it's an outpatient procedure. They come to the endoscopy unit, and then overall it takes about 1 hour. But in the preparation, the recovery time overall, it can be up to 3 hours. You're going to be put asleep by the anesthesiologist. You're going to get a breathing tube so that we can help you to manage the respiration throughout the procedure. The doctor's going to have the device pass through the throat, and then when it goes down to the stomach, the end of the device is like a hinge-like, so it can make a U-turn 180 degrees, looking up towards the valve. Then the doctor is going to pull the tissue around the valve down into the device. Then they're going to wrap a little bit. They're going to deploy the suture, The suture is made of like very nice type of plastics that gonna fall off over time. Okay, so then they're gonna do about 20 to 40 sutures around the junction between the food pipe and the stomach. And at the end of the procedure, we hope that we can create a stronger valve described as the length of the valve about 2.5 to 3 centimeters. And the degree that we can wrap it range around 270 degrees to 330 degrees. And that's actually the same anatomical change and the physiologic change that you can get from surgery as well. So when you wake up, we're gonna remove the breathing tube. You go to the floor, we monitor you overnight, and if you're doing well, you are ready to go home the day after the procedure.
Oh, wow. This is kind of amazing as well. All right. So what are the benefits of the teeth procedure?
So there are several benefits of the teeth procedure. So this technique is created based on the prior surgical option, the surgical treatment. So we measure the same thing. Number one, we measure the successful rate in terms of the technical success. So that is about 99%. And the adverse event is about only 2%, for which we can cause a tear or internal bleeding, which is very minimal. And the multiple national studies show that it can improve quality of life up to 91%. And actually, you can reduce the size of the hernia down into the abdomen up to 89%. And actually, the patient can stop taking the proton pump inhibitor for long term. This data lasted for now up to 8 to 10 years. So we have the long-term data already that is quite equivalent to the surgical fundoplication. And actually, if you have extra-intestinal manifestation of the GERD that I mentioned earlier, the chronic cough, the change of the voice, the globus feeling in the throat, or the asthmatic attacks, those symptoms tend to decrease over time too when you have less acid exposed into the chest. So those are the benefits of the teeth.
Oh, this is actually sound very advanced. I think it's quite advanced treatment, right? For this particular moment. Is it actually better than traditional surgery?
So I would say there are ongoing studies too that they compare head-to-head analysis. Let's say like the what we call the randomized trial between the surgical versus the endoscopic fundoplication of teeth after a surgical hiatal hernia repair. For those who have a large hernia repair, let's say in the operating room, the surgeons finish the hiatal hernia reduction. Then they randomize a patient into group 1 that they proceed with teeth, or group 2 that they proceed with surgical fundoplication. And the preliminary data show that they have equivalent acid suppression, equivalent improvement in terms of health-related quality of life. But what the patient experienced better in terms of teeth group is that they experience less bloating and belching. Why is it important? Think about if you have a procedure but you cannot get rid of the air from the stomach. That is quite bothersome. And why teeth may be better addressing that? Because if you think about the teeth anatomy, you pull the valve straight into the stomach, into the abdomen, and you distribute the pressure equally throughout your 20 to 40 sutures throughout that 270 to 330 degree, compared to when you do the surgical fundoplication. It's like you use one part of the tissue of the stomach and you wrap around the food pipe. So it's more twisting in terms of the mechanism. And that's how we believe that that patient may not be able to burp or pass the gas or having like the belching sensation. So that study is going on and is done by Professor Ken Chang at the University of California in Irvine. So it's to be answered, I would say, in the next few years.
Right. So it's actually more comfortable, right, for patients?
Yeah. So we believe that the main difference for patients who have same anatomy, if you go for surgery or you go for teeth, the teeth group could have better symptoms in terms of bloating and belching.
Okay. Thank you very much, Dr. Tossapol, for joining us today.
It's my pleasure.
Yes, and everyone else, please visit Bumrungrad.com to learn more about GERD and Transoral Incisionless Fundoplication, or TIF. Thank you everyone for your attention. This is Dr. Laura and Dr. Tossapol from Bumrungrad Hospital Talks. Please subscribe to our podcast for more episodes. Stay safe and healthy.
Thank you everyone and see you guys soon.